those 75,000 patients, we have about 6,700 people identified with diabetes at Rio Health Center. Of those, we see about 2,000 of those patients.
We primarily have Hispanic patients, and the incidence of diabetes with our Hispanic patients is very high. We also are the exclusive medical and pharmacy providers for an American Native Indian tribe, the Pasco-Yaqui tribe, the tribe.
We deal with underserved population, people who are uninsured, and so they have special needs.
Where I hear a lot about, the economic piece, people not having enough money, resources, how to eat healthier, where they can't get vegetables, very cheaply, it's more expensive to eat that way.
Yeah, I couldn't afford, they were saying $160 for the meter and then $80 for the test strips and stuff, and that's per month, and that's not with the things for testing, the needles or nothing.
I had to argue with the insurance company. I went a little better than a week with no test strips. So then I was still on the injectable insulin, so I would do my long acting at night like I was supposed to do, or I was doing it once a day. But I didn't dare touch my fast acting because I had no way to test my blood.
We have found way too often that readmissions for patients is because they didn't get their medicine. Okay, especially with an uninsured population. Okay, so it's our role to the next day call them, see how they're doing, see if they've got their medicines. Too often we don't know they didn't get their medicine until they come in for their visit.
They have so much depression and stress that a lot of times their diabetes might be less of a priority than other things that are going on in their life. But we always try to educate them and say, if you're not healthy, it's going to be even more challenging for you to be able to take care of these life issues.
They seem like they really care. They want to see you do better.
Because I'd always heard, depending on type of diabetes and stuff, that diet, exercise, you stand a chance of maybe getting off the medication. And I told my friend right there, I said, that's exactly where I'm going. I said, I won't stop doing that. And so far the numbers are impressive. They're very happy with it. So am I.
And also the patients coming back and saying, hey, thank you for referring to the program. And how come you hadn't referred before?
Yeah.
That kind of stuff. I think that helped speak volumes.
Improving care, not just medication, but just improving all the different components that come along with diabetes and addressing that. And I'm really happy that, this seems to be the way where Pharmacist is going. So
talk about good satisfaction there for the patient, for the clinical pharmacist, for the doc to know that now they've got somebody that's part of their team that they can rely on and receiving such great help.
The work that the Asheville Project has had the impact on that, and then the 10 City Diabetes Challenge, I think it's been very significant to show the value of pharmacists integrated into healthcare teams to have an impact on diabetes is exactly what we want to do here and what we've been doing, but I want to share it on a national scale. So Project Impact Diabetes is just a perfect fit. The fact that it's also addressing health disparities and the populations, again, another really, really good fit for us. So it's going to push the pharmacists in that role, which is very critical. And we need that because we have a lot of people with diabetes, but the overwhelming amount of people with pre-diabetes is significant. So we need an additional provider that's going to be accessible. And I think this is a good opportunity to show that on a national scale.